So these are my disclosures. Unlike most cardiac arrhythmias, atrial fibrillation cannot be mapped in search of reproducible trigger sites or fixed re-entry substrates for target ablation. To obviate to these limitations, empiric pulmonary vein isolation has been adopted as gold standard methodology for catheter-based curative treatment. I would say that the strongest data in the literature concerning the efficacy of catheter ablation using pulmonary vein isolation in the paroxysmal model are coming from Cabana. This was a large NIH-funded study randomizing 2,204 patients to either catheter ablation or antiarrhythmic drug therapy. The study undisputably showed that assignment to catheter ablation resulted in a better follow-up. Still, the success rates of using pulmonary vein isolation are not satisfactory. This segment of the slide highlights the outcome data from the Sequoia Hospital AFib ablation follow-up program, in which paroxysmal persistent and long-standing persistent atrial fibrillation patients were followed for 5, 10, and 15 years. And you may appreciate that after 5 years, only about 45% of patients, effective rates are observed in less than 50% of cases. and they come at 10 years of 36 and 15 years 25. And the success rates decreases as we move from paroxysmal to persistent and to long-standing persistent atrial fibrillation. To possibly improve outcome data, a number of ablation designs have been, I would say, incorporated in the ablation strategy by a number of authors. They include left atrial posterior isolation, ganglionited plexi ablation, usually 4 areas close to the pulmonary venous orifices, and linear lesion ablations at various sites of the left atrium, either the roof or the floor, or at the isthmus between the mitral annulus and any of the inferior pulmonary veins reams. Similar to PV isolation, left atrial wall isolation, ganglionated plexi ablation, and linear lesion ablation are empirical strategy. They do not require atrial fibrillation ongoing for the reasons we mentioned before, and do not require therefore the presence of the arrhythmia. It is important to know that the data coming from PV isolation are replicable whatever type of technology you're using. I would say the majority of data are coming from radiofrequency current ablation, but when recently compared to balloon cryoablation, outcome data in terms of outcome free of recurrences are superimposable when randomizing patients to either of the two technologies. And the same applies for pulse field ablation, according to a recent study published in the field. Pulse field ablation has long been claimed as a significant improvement in the ablation strategy of atrial fibrillation. However, we have to recognize that data coming from radiofrequency were solid and were corroborated by the long-term evidence that PV isolation was standing over time. So it would be hard for us to think or believe that any future technology would improve outcome data if the only target was pulmonary vein ablation. It was also claimed as a very safe procedure. However, in the only study that was consistently comparing the two technologies, there was one very procedural sudden death case in the pulse field ablation, which raises evidence that there is no procedure in electrophysiology which is safe enough to be considered completely safe. And what scared me when looking at this data is that this study was a study conducted in highly experienced centers, and if you have a death in the context of the procedure that you are not able to fix with whatever maneuver based on pericardial tamponade, you may consider that responsibility for this is a large hole produced by the technology itself. Now, when added to PV isolation in randomized controlled trials, left atrial wall isolation, ganglionated plexi ablation, or linear lesion ablations did not show any additional benefit as compared to PV isolation only. Most of these randomized controlled trials were performed in patients with persistent atrial fibrillation. So the next step would be to all the technologies, the techniques that we have addressed so far are based on an empirical approach. Having an individualized extrapulmonary vein ablation protocol would significantly increase the rigorosity of our methodology, and focal ablation of atrial tissue originating atrial exabytes that precipitate clinical AF may represent a highly attractive model for improving clinical outcome on top of PV isolation. Potential advantages of this technique would be represented by the use of traditional electrophysiology indicators. So we are not in an empirical field where we are dependent on the law of chance, and the ablation strategy would be tailored to the individual patients based on the findings that electrophysiology provides in terms of extrapulmonary triggers for arrhythmia. Evidence in favor of extrapulmonary triggers inducing atrial fibrillation have been produced early in the literature. In this report by Chen and co-workers of 2002, you may recognize on the surface EKG a sinus beat with a P wave on lead 2, 1, and V1, followed by an atrial exabeats that precipitates atrial fibrillation. The sequence of these findings is corroborated by the endocardial electrograms, showing that at the mapping site within the superior vena cava, the local electrogram recorded during sinus rhythm follows the local electrogram coming from the sinus area, but precedes any other site at the time when the atrial extrabeat precipitating atrial fibrillation occurs. And mapping and ablation of this site resulted in the Chen's report in complete cure of atrial fibrillation. So this is a proof of evidence that extrapulmonary veins triggers may precipitate atrial fibrillation in an individual patient. And the question is how to identify them, how to ablate them, and how to validate the model. In a more systematic report from the same group in 2003, so many years ago, the authors were able to show that extrapulmonary vein triggers were evident in a proportion of their collective. And another example is given here of a sinus beat followed by an extra beat that again precipitates, in this case, persistent atrial fibrillation. And the earliest activation sequence is recorded at the posterior wall of the left atrium, and therefore this area is considered as the trigger of pulmonary veins atrial fibrillation, non-pulmonary veins atrial fibrillation. In their collectives of 240 patients, they reported 28% of patients presenting with paroxysmal atrial fibrillation initiated by ectopic beats. So we are not talking about persistent here. We are talking about the scenario where we would consider pulmonary veins as a major precipitator of atrial fibrillation. And yet, in about 1/3 of cases, the authors could prove that atrial fibrillation originated from outside the pulmonary veins. The most frequent areas where they could find these triggers were the left atrial posterior wall, 38%, the superior vena cava, 37%, the crista terminalis, 14%, the ligament of Marshall, 8%, the interatrial septum, 1%, and the coronary sinus orifice, 1%. During 22 months follow-up, 63% of patients where acute elimination of the precipitating focus was obtained were free of atrial fibrillation recurrence of antiarrhythmic drugs. So the summary of these findings shows that ectopic beats initiating paroxysmal AF originate from non-pulmonary veins areas in about 1/3 of cases. Identification of these areas is not easy because atrial fibrillation does not spontaneously initiate during a nominal EP procedure in the majority of cases, and targeting non-PVI foci during a nominal EP procedure cannot be performed in the usual case. Surrogate endpoints in the absence of spontaneously initiated AF are frequent atrial premature beats that are occasionally present in these patients and catecholamine-elicited AF. But we don't know what is the clinical significance of these two conditions. And in addition, a number of pending items are preventing a solid evaluation of the predictive value of extrapulmonary vein ablation in the clinical setting. And particularly, what is the proportion of non-PVI foci initiating persistent AF? The systematic data that I showed you are coming from paroxysmal. And how to accurately identify non-pulmonary vein foci of clinical AF episodes, both in the paroxysmal and persistent model. And once identified, how to effectively ablate non-PVI foci of clinical AF until any of these three elements, which is of particular value, is not consistently proven, we cannot evaluate our model in the prospective setting. So I would like to conclude by saying the efficacy of AF ablation using an empirical approach is limited. I would say more limited than usually reported in presentations and publications. Extrapulmonary ablation does not appear to improve outcome in its present form. Non-PVI triggers of AF initiation represent a reasonable target for complementary ablation, but are currently limited by a number of impediments preventing the use of a solid investigational model to evaluate their predictive accuracy. Thank you very much for your attention.
Professor John Kam, Assistant Professor of Cardiology in Ain Shams University, and he will address the post-ablation blanking issue.
Good morning, everybody. I'd like to thank the organizing committee to inviting me for such an excellent meeting. The proposal of my speaking or presentation is the blanketing beating of the blinding period following AFib ablation, for sake of whom? This is the main question should be answered: for the sake of the patient, or sake of doctor, or sake of whom? When I thought to make my presentation, so let's answer such a question after going through such presentation. In the first few weeks, 2 months after pulmonary vein isolation, AFib can recur even when the patient may be free of atrial fibrillation on long term. That we know it is a delayed cure or delayed success of AFib ablation. Therefore, the expert consensus group recommend to measure the success of ablation therapy from 3 months after the procedure onward. This period is termed the blinding or the blankening period post-AFib ablation, as is now widely adopted in both clinical routine and clinical trial. As a result, a second ablation in patients with AFib recurrence within the blankening period, which we call its early recurrence, is not routinely done. Because of an episode of atrial fibrillation within the blankening period is considered to be isolated occurrence and not necessarily related to the dominant AFib mechanism. And as we know, the first episode of early recurrence occur within month 1 of the blankening period in about 80 to 90% of the patient with early recurrence in the first months. So, what about the arrhythmogenesis during the blankening period? A new arrhythmogenic substrate may develop at any moment after ablation, and electrical reconnection between the pulmonary vein and the left atrial myocardium is considered a cause of permanent ablation failure, justifying a new pulmonary vein isolation procedure. However, ablation success also occurs in patients with pulmonary vein reconnection. So the patient who have a pulmonary vein reconnection may have long-term cure of recurrence of atrial fibrillation. Therefore, prerequisite of complete electrical isolation to obtain therapy success and also the role of pulmonary vein reconnection in early recurrence should be questioned. So, what are the underlying mechanisms of early recurrence? Usually, it combined pathophysiological change, necrosis, ischemia, edema, inflammation, autonomic nervous disbalance, and tissue repair, including scar formation. And this is what we know that in short-term procedures such as edema, oxidative stress, and ischemia, necrosis, all can cause ectopy, can cause early coupling BECs, cause action potential short duration, and a long-term process, the inflammation, the autonomic nervous disbalance, tissue repair, and formation of stretch scar, all these can cause an early recurrence of atrial fibrillation. And I love this figure because in the early period of atrial fibrillation, post-AFib, we have two powers. The first power is what is called pro-arrhythmic power, and the second power is anti-arrhythmic power. In every patient after AFib ablation, we have this power, which is ischemia, edema, inflammation, autonomic necrosis. Even the anti-arrhythmic drug in the first 3 months may have a pro-arrhythmic power. And the anti-arrhythmic power is actually the parasympathetic denervation and the scar maturation and mechanical stimulation, as we can see, start after about weeks from the onset of ablation. So, the timing of early recurrence also play a role in the predilection of late recurrence. Early recurrence result in either late recurrence or delayed cure. So, we can see about all the possible scenario. One scenario is in the blind being after successful BVI, the pro-arrhythmic power is much much more than the antiarrhythmic power, probably because of pulmonary vein reconnection. If pulmonary vein reconnection occur, so the proarrhythmic power will maintain and cause late recurrence and failure of pulmonary vein isolation. But sometime, as we can see here in figure C and D, the proarrhythmic factor limited just to inflammation, and sometime after maturation of the scar, the antiarrhythmic power is much more evident, so this can cause late cure of pulmonary vein isolation. And recent published survey discussing the blankening period after AFib ablation, a European Heart Rate Association survey, revealed that 5 things. There is a general adherence of most of the doctor to 3 months program of blankening period, despite a call for shorter blankening period in patients with paroxysmal atrial fibrillation. Number 2, about the rate of early recurrence atrial tachyarrhythmia is about 25%, being higher for patients with persistent AFib compared to paroxysmal. And number 3, electrical cardioversion and reintroduction of antiarrhythmic drug, usually the preferred treatment for symptomatic early recurrence atrial tachyarrhythmia during blankening period. Number 4, there is a lower threshold to repeat AFib ablation during blankening period if the patient presents with well-defined non-pulmonary trigger, such as atrial tachycardia or typical atrial flutter. So I will repeat the procedure even in the blankening period. And number 5, 50% of the patient with early recurrence are perceived to experience late recurrence. 50%. So early recurrence of atrial fibrillation is not a simple thing. 50% of patients will develop late recurrence. This is a very important message to us. And early recurrence of atrial tachyarrhythmia are predictor of late recurrence at about 50% of the patient. And the theory of inflammation-induced proarrhythmic was the preferred one in the survey, but interestingly, most do not see the role of anti-inflammatory drug after pulmonary vein procedure. Most of them do not prescribe anti-inflammatory drug. And also a recent published in January 2024 about reconsideration or redefining of blankening period. It's usually insignificant of early recurrence after catheter ablation. And the finding here is usually the early recurrence in the first 4 weeks is different from those occurring in the 3rd or 2nd month. So the optimal blankening period duration usually should shorten to about 3 weeks to 2 months at maximum. And I'd like to hide this in that we should short the blankening period. For me, I usually, early recurrence in the first month, I usually ignore it. But early recurrence in the 3rd month is for me a very suspicious of late recurrence. So in my clinical work, an early recurrence after in the first month, usually I leave it alone. And lastly, the blankening period for sake of whom? For the doctor or for the patient? I believe it is for the patient because the incidence of early recurrence in the first month is about 80%.